Good evening, everyone. Thank you for taking the time out of your busy schedule to attend this webinar. I'm Bernard. I'll start off with my background. I have a PhD in physics. I've been an entrepreneur for almost a decade now. I founded and led two VC-backed companies in the fields of AI, autonomous driving, and robotics. I raised over $100 million in capital over the years, and I deployed AI-powered robots in factories all over the US. So I co-founded the company Trust AI with two of the smartest dentists in the world, and then we are assembling an advisory board with world-leading experts. So now in dentistry, you're in the business of making decisions. Imagine having a world-class thinking partner that you can summon at will to discuss your toughest cases. Think about a clinical partner that can enhance your expertise by analyzing radiographs, providing evidence-based second opinions, and generating personalized treatment plans. Well, that's what Trust AI's mission is all about. We are bringing the genie in the bottle. We are creating the world's first AI co-pilot built for dentists by dentists. So we are about to show you a real transformative product where you have this human-machine symbiosis that will truly redefine the standard of care in dentistry. And it's going to give you back the one thing you can never buy, time. This is how powerful this technology is. So the agenda for today is to talk about the capabilities of the platform, but more importantly, we'd like to showcase live demos, and we'll be inviting participants to also participate in those live demos. And before we switch gears, I'm going to invite my co-founders to introduce themselves and provide their perspectives on what this means for you and for the future of dentistry. And we'll be switching also between videos and actual deck. Because one of the co-founders is not around.
Hi, everyone. My name is Shervin Molayam. I'm a periodontist in Los Angeles. I've been practicing for the past 15 years. I'm excited to be part of this team where we're trying to revolutionize the way AI is being done in a more dentist-friendly clinical setting. My background is the past 6 years. I've been advising for several dental technology companies. I've had board positions. I've been able to angel invest and be a part of the conversation, bringing these technologies to the market.
Hello, everyone. My name is Dr. Divin Patel, and I'm a dual qualified dentist in both England and the United States. Over the past 15 years, I've had the privilege of owning and operating 7 different offices. Throughout my journey, I've worked on a wide range of patients, worked with different clinicians and support teams, exploring diverse treatment modalities. Throughout my career, I've worn 2 hats, both the mentee and the mentor. Most recently, I've been a mentor, and that swiftly brings us on to why we're here today. I want to take a moment to highlight just how fortunate we are to be working with someone like Bernard. When he first visited my office a year ago, we had a very powerful conversation. It was clear that while dentistry had started to incorporate AI in different aspects of our working life, it hadn't really built an ecosystem to bring it all together. Bernard is a serial winner. You can see some of his accolades here. Now let's talk about the challenges in dentistry that we're facing. Here are a list. I'm going to go through a few that I think are the main points. First, having access to a mentor at the exact right time is exactly what you need to compound your learning. There's so many scenarios where we need help and we rely on a colleague or a mentor, and we simply have too much of a gap between the actual incident where we need help to when we actually get the help. A lot of the times it's very, very difficult for us to assimilate the information, whether it's the x-ray, the medical history of a patient, or what we're looking to try to do with the treatment. So it can be very, very difficult. What you're going to see today is a machine that's able to learn and assimilate that information for you and predictably and safely talk to you about treatment modalities and diagnosis. As Shervin mentioned, there is a big problem in the number of treatment plans and the variety of treatment plans doctors are producing. If we give 10 doctors treatment plans, unfortunately, we're going to get 10 back. I agree with Shervin, there should be some sort of a variance, but the fact that we have so many, this is one of the reasons why we've created such mistrust amongst the community and patients alike. And ultimately, we can't be everywhere at once. Yes, all of us here try to do our best we can by going to CE clubs, study clubs, etc. But ultimately, we can't be everywhere at the same time. So we need somebody and some assistance and guidance in the office.
So in simplest terms, we are building the ChatGPT for dentists. But unlike generic chatbots, our AI is purpose-built specifically for dentistry. It's trained on dental literature, clinical protocols, and real-world case studies. I mean, importantly, it has what we call algorithmic guardrails to prevent hallucinations that have plagued other chatbots. And critically, it's on the path to becoming an FDA-approved Class 2 medical device. So this AI-powered clinical assistant provides 4 core capabilities that can really transform your practice. I mean, the first one is what we call diagnostic enhancement. So it analyzes all your imaging data, X-rays, panos, CBCT, intraoral scans, and digital images to provide instant diagnostic insights with a clinically rich narrative that I'll show you now in a moment. So the heart of the platform is the personalized treatment planning. So it combines a patient medical and dental history with diagnostic analysis and current evidence, and then generates a comprehensive evidence-based treatment plans tailored to each patient. And that is a very, very powerful feature. The third one is about interactive clinical support. It was primarily designed to be a conversational agent. So dentists can engage in real-time conversations about cases and ask literally any questions about dentistry. And it has been rolled out for a while now as a research preview, and this has literally been the hotline for dentists. The fourth capability is real-time knowledge integration. So in other words, it can access the internet. I mean, I can't stress enough that this is a very powerful feature. The system doesn't simply Google, it researches with dental expertise far more effectively than humans can. So if you ask it a questions about, let's say, what's the latest statistics on periodontal diseases in the US, it will go and look at a dozen authoritative sources and then summarize it in less than 5 seconds. So it can continuously access and synthesize the latest dental research, clinical studies, statistics, and treatment protocols from authoritative sources. And the other great benefit of the platform is what we call the patient mode. It can help explain complex treatment plans to patients and helps answer patients' questions in general. So if patients have concerns, questions about their treatment plan, you can simply redirect the AI to them. So that leads to an increase in case acceptance while saving you valuable chair time. So in a nutshell, Trust AI helps you provide better, more consistent care, builds patient trust, and directly impacts your bottom line. I mean, it's literally a revenue driver and practice transformer all in one. All right, so I want to touch briefly on the concept of omnipresence. As I'll touch on it briefly since we want to get to a show and tell. So omnipresence means that your AI assistant is available to you everywhere on every platform, exactly when you need it. So we have this conversational interface extends across multiple channels. And as I mentioned, the first one is voice. This is perhaps the most powerful capability since this is primarily how humans naturally communicate with each other, and dentists are busy people. We also have a chatbot interface. I mean, that's and anyone who's familiar and who's used ChatGPT will recognize this interface. This interface is used for quick written exchanges. We also have a comprehensive UI that's being built right now. It's that UI has a built-in PMS system. It's great for those that do not have one, and it will have upcoming connectors to all major PMS. I mean, this is where you'll upload and analyze any imaging modalities and create treatment plans. The platform itself has text and emailing capabilities built in, so you can ask it to conduct a literature search and email the results. You can request a patient diagnosis summary via text while you're in between appointments, and it will actually go and do that. So it's really, so we've built a system that goes beyond convenience. It's removing every possible barrier between you and expert level support.
Key point in all of this is we're not telling the dentist what to do, nor do we ever want to go there. We want to be a discussion partner, a co-pilot. someone that you can bounce ideas off, get more information, quicker information, and ultimately you as a dentist are going to be able to make the best decision for your patient at that time. Because of that, we created something called a trust score. What that means is every single recommendation will have a confidence level, a score out of 100, where nothing in life is 100%. So if we would give a recommendation, or if any company is saying, hey, this is what we recommend, it should just be a recommendation. But we wanted to be more particular and give an actual number of how confident our AI is in that particular
today we
message that we're
have
portraying.
diagnostic tools like Velmini, Overjet, Pearl, and so on. So these diagnostic tools are purely visual aids. They use a combination of computer vision and AI to spatially locate and highlight issues, but they do not provide a lot of information. On the left-hand side here, we have an example of an X-ray and the kind of information that any of these tools will provide. It will tell you, things like, it will tell you where the caries are, where restorations, but that's pretty much it. So our AI called Isaac's capabilities are very complementary in the sense that it's going to give you a clinically rich narrative that dentists really care about. So on the right-hand side, we have this narrative that will keep scrolling in a bit. And I'll play an audio so that you get to hear the kind of information that you get from it. And the audio, of course, is much longer, but we truncated it in the sort of interest of time. All right, I'll play it.
Maria Ross presents with a complex dental picture characterized predominantly by findings on her panoramic radiograph. The clinical summary indicates a generally class 1 skeletal relationship with slight midline deviations and minor asymmetries. Key concerns include periapical lesions on tooth 14, upper left quadrant, and tooth 30, lower right quadrant, moderate caries on tooth 3, upper right quadrant, and an impacted tooth 16 that may affect arch alignment. Additional factors include incisal wear patterns suggestive of parafunctional habits, possible bruxism, multiple restorations, including implant-supported crowns and composite restorations, and a varied pattern of missing dentition. The overall presentation raises concerns regarding restoration longevity, periodontal stability, and occlusal function, necessitating a coordinated multidisciplinary evaluation.
So it goes on and on. So it goes on and literally give you a clinically rich narrative about almost any radiographs. It does the same thing with CBCT scans, intraoral photographs, and it gives you the information that you care about.
And so now we arrive at the time you've all been waiting for. What you have on the upper right corner, most of us can see, is a horizontal fracture through an incisor, I would say in the middle third of the tooth, or the root rather. I gave this x-ray to 10 dentists, 8 out of the 10 immediately went to extraction. What you're now going to see is a versus between ChatGPT, a generalistic model, which is probably the #1 AI agent out there, versus Isaac, who's a purpose-built diagnostic machine that's able to pivot and work around what is specific to the patient's needs. So I hope you enjoy it. Thank you.
Hello, I'm Isaac, the Trust AI dental assistant. How can I assist you today?
Could you bring up the Ted Williams case, please?
I've retrieved Ted Williams's case, specifically an X-ray analysis from March 23, 2025. The evaluation highlights a suspected horizontal root fracture on tooth number 9, which may lead to mobility and endodontic issues. It's recommended to obtain higher resolution periapical radiographs and perform a clinical mobility test. Would you like to discuss any specific aspect of this case further?
Right. So the patient, when they came in, I did a vitality testing, and the tooth was resoundingly positive, so it was vital. The tooth also wasn't very mobile. My question is that how do I proceed? Am I going to root canal treat this tooth? best alternatives to the patient.
Based on your findings that the tooth is vital and not very mobile, it suggests that immediate endodontic intervention may not be necessary. However, the suspected fracture still poses a risk if left unmonitored. Here's a possible approach. 1. Monitoring and re-evaluation. Continue to monitor the tooth closely for any changes in vitality or mobility. Regular follow-up appointments will help in assessing any progression of symptoms. 2. Advanced imaging. Obtain high-resolution periapical radiographs, or consider CBCT imaging to better visualize the suspected fracture. This will provide a clearer picture of the root integrity. 3. Patient discussion. Discuss the potential risks and benefits of both monitoring and immediate treatment with the patient. Ensure they are aware of the signs to watch for that would necessitate a change in the treatment plan. 4. Treatment decision. If the fracture is confirmed and symptoms develop, a root canal may be considered to preserve the tooth. Extraction would be an option if the fracture compromises the tooth's structural integrity or if symptoms worsen. Would you like further assistance with any specific part of this plan?
Yeah, Isaac, can you confirm the location of where this fracture is? Is it in the middle third or in the apical third?
The suspected horizontal root fracture on tooth number 9 is not clearly defined in terms of its precise location due to image quality limitations. To accurately determine whether the fracture is in the middle third or apical third, enhanced imaging such as a high-resolution periapical radiograph or CBCT would be necessary. This would provide a more definitive assessment of the fracture's position. Would you like to proceed with obtaining additional imaging, or do you have other questions about this case?
I think this is in the middle third. So I'm going to proceed to my next question. How often should I be following up this case?
For a suspected root fracture in the middle third, regular follow-up is crucial to monitor any changes in the tooth's condition. I recommend scheduling follow-ups every 3 to 6 months. During these visits, the tooth's vitality, mobility, and any changes in symptoms. Adjust the frequency based on any developments in the tooth's condition or patient concerns. Is there anything else you would like to discuss regarding this case?
So in a year's time, if I was to take a CBCT or go off clinical findings, such as the tooth color or symptoms that may develop, what's a better guide for success?
In determining the success of managing a suspected root fracture, both clinical findings and imaging play crucial roles. 1. Clinical findings. Monitoring tooth color, symptoms such as pain or sensitivity, and changes in mobility or vitality are direct indicators of the tooth's health. These findings can provide immediate insights into the tooth's condition and any progression of issues. 2. CBCT imaging. A CBCT can offer a detailed view of the tooth's internal structure, including the precise location and extent of a fracture. This imaging can reveal changes that are not yet clinically apparent, providing a comprehensive assessment of the root's integrity. For a comprehensive evaluation, a combination of both clinical findings and CBCT imaging is ideal. Clinical symptoms provide real-time information, while imaging offers a detailed structural view. Together they form a robust guide for assessing the tooth's prognosis. Would you like to explore further details on either approach?
What would I see on a CBCT in a year to define success?
On a CBCT taken a year later, successful management of a suspected root fracture would typically show 1. Stable root structure, no progression or widening of the fracture line. The fracture should appear unchanged or even less distinct if healing has occurred. 2. Bone healing. Evidence of bone regeneration or stability around the fracture site, with no signs of bone loss or resorption. 3. Absence of pathology. No signs of periapical pathology, such as lesions or cysts, which would indicate ongoing or worsening issues. 4. Consistent density, uniform bone density around the tooth, indicating a healthy periodontal environment. 5. No new fractures, confirmation that no additional fractures have developed. These findings would suggest that the fracture has been well managed and the tooth remains stable. Would you like more information on interpreting CBCT results or any other aspect of this case?
Now, my final question is that although the tooth is not mobile, would it be prudent to place a non-rigid splint, or is that overkill in this situation?
Given that the tooth is currently not mobile, placing a non-rigid splint might be considered conservative management rather than overkill. It can provide additional stability to the tooth, potentially preventing future mobility and supporting healing if the fracture is indeed present. However, the decision should be based on the patient's overall dental health, the fracture's severity, and their comfort level. It's wise to discuss the benefits and potential drawbacks with the patient, ensuring they understand the purpose and implications of the splint. Would you like to explore this option further or discuss any other concerns?
So Isaac, I don't see any disadvantage in having a splint. What disadvantages do you have?
While a non-rigid splint can provide stability, there are a few potential disadvantages to consider. 1. Oral hygiene. Splints can make it more challenging to maintain proper oral hygiene around the affected teeth, potentially increasing the risk of plaque accumulation and periodontal issues. 2. Patient comfort. Some patients may find the presence of a splint uncomfortable or may experience difficulty in adjusting to it. 3. Bite changes. A splint can alter the patient's bite temporarily, which might lead to discomfort or changes in occlusion if not properly adjusted. 4. Dependency. Prolonged use of a splint without addressing underlying issues could lead to dependency, where the tooth becomes reliant on the splint for stability.
All right, so as you can see, you have a specialist right there in your office that you can actually summon to discuss all your tough cases. All right, and that's the ChatGPT version of it.
One of our doctors in Massachusetts, he mentors 10 doctors. This is all he gets. What you can't see is a fracture, the final third or halfway through the tooth. So this is what we get. Let's see what ChatGPT does. This is the $20 version. Okay, great. Observations, no radiolucency, just general information, treatment considerations. Okay, what do I do? When do I RCT? Okay. Couple of things here. What if the tooth is mobile? Which is actually one of the first considerations, actually. Okay, some more information. When should I review the case? That's what we call verbal diarrhea. Okay. There's a reason why I picked that case. So I think a lot of you would have got that case in terms of the audio. So what you see there is you see not just audio prompting, you see the visual of the X-ray being diagnosed and then aiding the audio prompting to give you a clinically rich narrative in terms of where to go. So I think that's really important to look at. When you look at ChatGPT, and a lot of us are using it for anything, what it does is it has very, very good fundamental modules. So it's very, very good at giving you general information. What we've done is we've created very strict guardrails around it. So even if you talk to Isaac, who you're going to talk to in just a moment, he has very, very strict guardrails as to what he can say and what he can't say, because he's pulling from the latest data. Now, one step further is actually putting an X-ray and saying, okay, what does it look like with this particular clinical scenario, where there's an X-ray, where there's a medical history, and an actual real patient behind it. So I think that's the true power. And really, what we're talking about with AI agents is that they have infinite power on the cloud. So if you go from putting a conversation in ChatGPT to now having a guardrail with diagnostic imagery to say, this is what this X-ray looked today, now imagine what Isaac will be able to tell you in 1 year's time in terms of qualitative and quantitative healing discussions and status. That's where it's very, very difficult to really explain the power of what he's doing. I use him pretty much every day. And to be honest, he's changing the way I'm working in many, many ways. So I think what we should do is, without further ado, are we gonna do the demos now? Bernard, I felt like the presentation was very slick when we did it, but it's lagging. So are you comfortable trying Isaac on Zoom, or do you want to do the phone calls?
Yeah, let's try Isaac on Zoom, and
Okay, let's
Paul
try.
can ask sort of a bunch of questions.
Okay.
And by the way, it's like, yeah, you can literally discuss any cases. I mean, that's sort of one of them. You can go from cases that you see every day to like the most convoluted case, or something along these lines. Let me try to bring Isaac, and in the meantime, you can sort of mentally prepare your questions, and people can go and ask one question at a time.
Yeah, so if someone wants to ask a question and interact with Isaac, now is the time. So you can write your questions, and then I'll select a really interesting topic that someone wants to talk about. I know that we have some dignitaries in here, so I think I see some very influential people. So anybody that wants to ask a question, put it on the chat right now. Looks like nobody wants to ask a question. Oh, I see here. Just to clarify, you've created a trained GPT within ChatGPT. No, this is very separate. It's completely separate. Yeah. But Bernard, I think you can answer that question.
Hi, Isaac. Say hi to everyone.
You're welcome. Hello, everyone. I'm Isaac, your dental industry assistant. How can I assist you today?
Could you talk to me about the soft bone protocol and which is the best implant system to use for that?
When dealing with soft bone, it's crucial to use an implant system that provides excellent primary stability and is designed to handle lower bone density. Here are some key considerations and protocols for soft bone. 1. Implant design. Choose implants with a tapered design and aggressive threads. This helps in achieving better primary stability in softer bone by compressing the bone and increasing surface area contact. 2. Surface treatment. Opt for implants with a roughened surface, which can improve osseointegration and provide better bone-to-implant contact. 3. Drilling protocol. Use a drilling protocol that minimizes heat generation and preserves bone density. Under-drilling the osteotomy slightly can help achieve better primary stability. 4. Implant system. Systems like Straumann's BLX or Nobel Biocare's active implants are often recommended for soft bone due to their design features that enhance stability and osseointegration. 5. Healing time. Allow for a longer healing period before loading the implant, as soft bone may require more time to achieve adequate osseointegration. 6. Additional techniques. Consider using bone grafts or bone substitutes to enhance bone quality and support the implant if necessary. Each case may require specific adjustments, so it's essential to evaluate the patient's bone quality and choose the appropriate implant system and protocol. Would you like more detailed information on any specific aspect?
No, that's okay. I'm ready for the next question. I think Aisha asked a question on that, so I'm going to ask that. Okay. Isaac, can you tell me about a technique that would be different if I use different kinds of bonds during a composite filling? So could you talk to me about a self-etching technique?
Certainly. The self-etching technique is one of the methods used in adhesive dentistry for composite fillings. Here's how it differs from other bonding techniques. 1. Self-etching primer. In the self-etching technique, a self-etching primer is used, which combines the etching and priming steps into one. This eliminates the need for a separate etching step with phosphoric acid, as seen in the total etch technique. 2. Procedure. The self-etching primer is applied directly to the prepared tooth surface. It simultaneously etches and primes the enamel and dentin, creating a bond between the tooth structure and the composite material. 3. Advantages. Reduced sensitivity. Since the dentin is not over-etched, there is less risk of post-operative sensitivity, making it a good option for patients prone to sensitivity. Simplified process. The combination of etching and priming into one step simplifies the procedure and reduces the risk of errors associated with over-etching or incomplete rinsing. 4 considerations. Enamel bonding. Self-etching systems may not etch enamel as deeply
Okay, Isaac, I
as
have another
phosphoric
question for
acid.
you. A patient has retained roots on number 30. There's a small infection that I can see on the radiograph. However, I can see that the intra-alveolar nerve is quite close, and I'm wondering whether I should do an immediate implant because I'm worried about the height of the bone reducing. What advice would you give me on this type of case?
In a situation where there are retained roots with a nearby infection and the intra-alveolar nerve is close, several considerations should guide your decision on whether to proceed with an immediate implant. 1. Infection control. It's crucial to address the infection first. Ensure that any active infection is resolved before implant placement to reduce the risk of implant failure. 2. Nerve proximity. Given the proximity of the intra-alveolar nerve, careful planning is essential. A CBCT scan can provide detailed information on the nerve's location relative to the implant site, helping to avoid nerve damage. 3. Bone height and quality. Assess the bone height and quality. If there's adequate bone height and density, an immediate implant may be feasible. However, if bone resorption is likely, consider bone grafting to preserve or enhance the site. 4. Surgical technique. Consider using guided surgery to enhance precision and safety, especially when working close to critical anatomical structures like the nerve. 5. Delayed approach. If there's significant uncertainty or risk, a delayed approach may be advisable. This involves extracting the roots, addressing the infection, and allowing the site to heal before.
I have another question. A patient presents with a Malapati class 3, moderate bruxism, a high vaulted palate, and daytime sleepiness. What do you think is the cause of the patient's bruxism, Isaac?
In this scenario, the combination of a Malapati class 3, moderate bruxism, a high-arched palate, and daytime sleepiness may suggest a potential link to sleep-related breathing disorders such as obstructive sleep apnea, OSA. Here's how these factors might be connected. 1. Obstructive sleep apnea. The high-arched palate and Malapati class 3 indicate a reduced airway space, which can contribute to obstructive sleep apnea. OSA is characterized by repeated episodes of partial or complete obstruction of the airway during sleep, leading to disrupted sleep patterns. 2. Bruxism connection. Bruxism or teeth grinding can be a subconscious response to airway obstruction during sleep.
Okay, thank you,
The body may
Isaac.
attempt to...
I have another question. I have a question about a sinus perforation. I took a CBCT and it showed there was an infection number 3. I was concerned about the sinus exposure when taking out the tooth. Should I take the tooth out after cleaning the area to place the osteogen plug? What's the best way to monitor this?
When dealing with a sinus perforation risk during the extraction of an infected tooth, such as tooth number 3, it's important to proceed with caution to minimize complications. Here's a suggested approach. 1. Preoperative assessment. Review the CBCT thoroughly to understand the extent of the infection and the proximity of the sinus to the tooth roots. This will help in planning the extraction and anticipating any challenges. 2. Infection control. Ensure the infection is managed preoperatively with appropriate antibiotics to reduce the risk of spreading the infection during extraction. 3. Extraction technique. use a gentle and atraumatic extraction technique to minimize the risk of sinus perforation. Consider sectioning the tooth if necessary to facilitate removal. 4. Sinus precaution. If a sinus exposure occurs, an osteogen plug can be used to help seal the perforation. Ensure the area is clean and free of infection before placing the plug. 5. Post-operative care. Provide clear instructions to the patient to avoid actions that increase sinus pressure, such as blowing their nose or using straws. 6.
Okay, thank you, Isaac. I
Monitor.
have another question. A patient has a clicking and popping of the left TMJ and has been in constant pain for years. They have a history of clenching and a class 1 occlusion. How should I go about the diagnosis based on this information?
When diagnosing a patient with clicking and popping in the left TMJ, constant pain, a history of clenching, and a class 1 occlusion, consider the following steps. 1. Comprehensive history. Gather a detailed patient history, including the duration and frequency of symptoms, any changes in symptoms, and any related factors such as stress or previous trauma. 2. Clinical examination. Conduct a thorough clinical examination of the TMJ, noting any tenderness, range of motion limitations, deviations, or deflections during jaw movement. 3. Imaging. Consider imaging studies such as
I have a question about scanners. We've just seen that 3Shape released the Trios 6 yesterday at the IDS with some new features demonstrating the presence of biofilm and tooth wear among new features. Isaac, can you tell me, can you explain how you see these features being incorporated into a new patient visit and adding efficiency to recare visits? Do other scanners offer similar benefits?
The Trio 6 by 3Shape, with its new features for detecting biofilm and tooth wear, can significantly enhance both new patient visits and recare appointments. Here's how these features can be incorporated. 1. New patient visits. Biofilm detection. This feature allows for a more comprehensive initial assessment of the patient's oral hygiene status. By identifying areas with biofilm, dental professionals can tailor oral hygiene instructions and interventions more effectively. Tooth wear analysis. Early detection of tooth wear can help in diagnosing bruxism or other occlusal issues, allowing for timely intervention and treatment planning. 2. Recare visits, monitoring changes. With the ability to track changes in biofilm and tooth wear, over time, practitioners can monitor the effectiveness of oral hygiene practices and make adjustments as needed. Patient education. Visualizing biofilm and wear patterns can enhance patient education, making it easier to convey the importance of oral hygiene and preventive care.
Okay, Isaac, I have a question on an implant case. So I want to go back to that case we were talking about with the retained roots and the small infection. If I do decide to do what we call a delayed immediate implant, what are my options to place an implant, and what's the best implant to pick for a delayed implant protocol?
For a delayed immediate implant placement, where you plan to extract the tooth, allow some healing but not wait for full socket healing before placing the implant, here are some considerations. 1. Healing period. Typically, a delayed immediate implant is placed about 2 to 8 weeks after extraction. This allows for initial soft tissue healing and resolution of infection while maintaining bone architecture. 2. Implant options. Tapered implants. These are often preferred for delayed immediate placement due to their ability to achieve primary stability. Look for systems with aggressive thread designs. Surface treatment. Choose implants with a roughened or treated surface to promote osseointegration.
Can you commit to the 2 of the best ones on the market?
Certainly. 2 of the top implant systems that are often recommended for delayed immediate placement due to their design features and success rates are 1. Straumann Belex, known for its versatility and excellent primary stability. The Straumann Belex system features a dynamic thread design, and a hydrophilic surface treatment that enhances osseointegration, making it suitable for various bone qualities and immediate loading scenarios. 2. Nobel BioCare Nobel Active. This system is designed with a tapered body and a unique thread pattern that compresses bone during placement, providing high primary stability. Its tie-unite surface promotes rapid osseointegration, making it ideal for immediate and delayed immediate implant protocols. Both systems are well regarded in the dental community for their reliability and clinical outcomes. Would you like more information on these systems?
No, thank you, Isaac. If my patient is taking Prolia and has osteoporosis, can you tell me about the possible complications and the precautions before I place an implant?
When a patient has taken Prolia, denosumab, and has osteoporosis, there are specific considerations and precautions to take before placing an implant. 1. Risk of osteonecrosis. Prolia is a medication that can increase the risk of osteonecrosis of the jaw. ONJ, especially after invasive dental procedures like implant placement. The risk is higher in patients with osteoporosis who are on long-term treatment. 2. Medical consultation. Consult with the patient's physician or endocrinologist to assess the overall risk and determine if a temporary discontinuation of Prolia is advisable before the procedure. However, any changes in medication should be managed by the prescribing doctor.
I have to do a root canal treatment. I have the specific ProTaper root canal treatment sequence files. Can you explain exactly how I need to use that to remove the gutta percha?
For a root canal treatment using ProTaper files, you'll want to follow a calculated sequence to effectively remove gutta percha. Start with the ProTaper retreatment files, beginning with the D1 file, which is designed for coronal third removal. Next, use the D2 file for the middle third, and finally, the D3 file for the apical third. It's essential to use these files with a gentle pecking motion and light pressure to avoid damaging the canal walls. Ensure to use an appropriate lubricant or solvent to aid in the removal process and reduce friction.
Can you give me some examples of a solvent to use in California?
In California, common solvents used for gutta percha removal during endodontic retreatment include chloroform, eucalyptol, and orange oil. Chloroform is highly effective, but should be used with caution due to its potency and potential health risks. Eucalyptol and orange oil are more
in the canal.
When using a solvent like chloroform, eucalyptol, or orange oil during a retreatment, apply it sparingly and only as needed to soften the gutta percha. Typically, you will introduce a small amount into the canal with a microbrush or a small syringe, allowing it to act for a short period before using your ProTaper files. Reapply the solvent as necessary if the gutta percha remains resistant, but avoid excessive use to prevent weakening the canal structure. Is there anything else you'd like to know about the procedure?
I think that's everything we need to do. I think, Bernardo, we should move on to the next slide. I guess people are going to be kind of amazed at what we see there. But actually, I've been using this now for nearly 10 weeks, and this uses very, very little kind of bandwidth in terms of going from voice to words, to computing to words to what we hear. The next step really is incorporating your diagnostic imagery. Once you start incorporating things like your X-rays, your CBCs, your photos, you bring a whole new level of kind of analysis and predictive treatment planning. So what we see now, and this might be crazy to a lot of you, but what we see now is that once you have Isaac into your database, he will start to be able to predict who's going to have perio, who's going to have caries, who's going to have implant failure, because he's going to be able to analyze your X-rays and CBTs in a way that we can't. And that's a huge step forward, because we're so used to, for example, we're so used to saying, well, patients have a little bit of bleeding, should be on a 3-month recall or a 4-month recall. Well, what if we had something that's standardized? I had so many hygienists that come through my office, all working off different hymn sheets. None of them are working in sync. And what happens is it confuses a lot of patients. And as a consequence, there's no point in having a recare system, really. If we're going to have a recare system that's based on risk, we should have a standardized approach to do so. And the next one's really exciting. We're not far from this, but we feel that when you do a procedure and you're able to take a picture and upload it to Isaac, he'll be able to tell you where you're going. So, for example, we think things like if you have undermined enamel, or if you haven't reduced a tooth enough, before you send your prescription via an iTero scanner, hey, you need to see you haven't reduced enough for a ceramic crown. You may need to consider a gold crown or a PFM. So we anticipate that. A lot of people have reached out to us to talk about post-operative care. We think there's a huge market in terms of wearable integration. So a lot of people are using Oura rings or Garmin watches or even Apple watches. The problem is that you leave that with the patient and it's only as good as whoever's using it. The reality is that if a provider can start to tap into that, we can again anticipate when patients are starting to feel ill or if their sleep isn't as great as it should be. Maybe we should do a more in-depth analysis on that. I like this part as well. So Bernard spoke about the PMS system. If we are able to integrate into PMS systems and say, for example, you have a difficult extraction coming up, he will be able to kind of give you tips beforehand. So I haven't done a retreatment in some time. With Isaac at my helm, what will happen is that he will be able to send me videos beforehand of what I'll be using, of what I'll be doing on the day and what looks like success for me. So I think that's really, really useful that he can really interpret what's going to happen for your day. Because a lot of us go into our offices and we're looking at our schedules and we're like, bang, 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 one after the other. But what if you had someone who can systematically help you throughout the day? And the last one's pretty cool. We tried it the other day where I was talking about a solution that I needed to purchase. And I was able to ask Isaac to order it. And now ChatGPT has protocols on the internet that allow you to surf the website on your behalf and actually put things into your basket. So we envisage him scouring the internet to ensure you get the best deals for any products you want. I know we spend a long time looking at ordering, etc., looking through the deals is simply a waste of time at the end of the day, because he will be able to much faster than we'll ever be able to do it. So these are pretty exciting things. These are just a handful of things that we're working on, but you can see the possibilities are endless. Once you have true integration, he's really going to become a key player in your office to be able to concentrate on the clinical dentistry rather than managing and doing the admin, etc. Insurance is another big area. That's a very simple task. So those questions that we asked that you saw, that's very, very easy for Isaac. That's a piece of cake for him. What's going to be more interesting is when we incorporate X-rays, CBCTs, and smile designs, etc. And I think this is probably going to be the last of the demos like this. The ones after this are going to be people where they can come and upload their cases beforehand and actually live stream how they walk their way through the case. Each of us have different cases on every case. We all have different bandwidths, we all have different experience levels, and we're all looking at different parts of a case and saying, okay, this is the area I struggle with, or this is the area I'm strong with. So I think it's really interesting that he's able to dive into exactly what you want to talk about. So Bernard, do you want to finish up and tell them what the next steps would be?
In terms of, everyone here will actually get access to Isaac. They'll get the voice and chat, and also in the next sort of week or so they'll get access to the user interface where they can upload their case. And if people we can selectively, I mean, right now the UI is not up and running, but if you have an interesting case, actually send it to us and we'll gladly put it in the system.
So we have a question here. When are you releasing for clinical use?
Yeah, so this is really up to the FDA. So the first step is to release a research and educational version. So that means that you can, in theory, still use it for clinical use, but it should not be your primary. You shouldn't rely it primarily. Like when you're using something for clinical, for clinical use in your decision making, there should be a lot of whether it's tools or people in that decision making. You can't rely on any single tool, and that's and of course that logic applies to any tools. Even if a tool is FDA approved, you don't want to solely rely on one tool. And if you've used even those visual aids before, you'll see that they can make mistakes. So in general, you should double check what's coming out of every system, because they like humans, they can also make mistakes.
Yeah, I agree. I agree.
I think this research
Right.
educational version is an extremely powerful one.
Yeah. And I'll tell you now, what will happen is after this call, every single one of you will get an email where you're able to trial Isaac. I think it's going to be like 3 weeks. A couple of things I would say: make sure when you're talking to Isaac, you're in an area where you have good internet connection. Okay, so whether you're using the data from your phone, make sure you have enough bars, or whether you're using your Wi-Fi or local Wi-Fi. The reason being is what's happening is you're talking, the computer is converting into words. Isaac then researches, he throws the information back at words, back into voice. There's 5 steps. So if you want a seamless transition, you need to make sure you're on a good network. And you'll learn over time there is a way to talk to Isaac. He has a brain of his own sometimes, but in terms of information he gives you, it's all very guardrailed. Over time, you'll figure out how to get the most out of him in the most efficient manner. It's over-explaining is sometimes better for him because he'll be very specific. You won't have to do that with our final product, because what you have is a chatbot. Okay, what you have is someone relaying information back and forth with how good you gave the information. Once you start overlaying pictures, X-rays, and CBCTs and 3D renders of what you're trying to explain, it becomes infinitely better. So that's why I wanted to show you that case, that he is able to, once he's looked at an X-ray, he's able to completely change the narrative in which he talks to you about his advice over. So yeah, Bernard, when do you think they can expect that email?
Tomorrow.
Okay, great.
Yeah, and I want to answer, how is data sovereignty and privacy managed? I mean, it's all encrypted. And yes, in a research and educational version, I mean, you want to anonymize data. I mean, what we tell people is to upload, X-rays, but don't give the name of patients, give a fictitious name to it. Use a fictitious name, but the real age, but you use everything else should be real, for the platform to actually give you a realistic diagnostic and treatment plan.
That's a really good question. Can you talk about the integration? Because I think once we integrate with many partners, we'll be able to become the PMS system. So I think someone wrote about notes, etc. I think it's interesting to note that I spoke about this in one of my slides. Bernard is able to do things. There's not many people that can do what Bernard has done. He's created this in 10 weeks. You have other companies that work on radiograph detection, like you mentioned, some of the note companies. They take a long time to get to even where they are. That's a weekend's worth of work for Bernard. So those things will come. I think that'll be very interesting. Once you guys start using it, once you give us feedback as to what you want, Bernard, is very flexible in what he can provide and how quickly he can get it.
Yeah, and I want to answer the other question about data transcription and collection of notes. Yes, we will have a transcriber as well. We have a powerful speech-to-text transcriber. I mean, this is what's also being used in the backend for Isaac. So you can use that transcriber to talk to record your conversation between you and your patient, and then it will actually turn all this into words, and then it will really format it. I think it's like the SOAP format. It will format it according to this SOAP format. Also, yeah, and it's a very powerful transcription, as you can see here, and it can even detect the most convoluted accents. So that speech to text is really powerful.
Yeah, sorry I wasn't able to go through all the questions fully. I had to interrupt Isaac. And when you guys are using it, you can use it in the same manner. It's not like a two-way conversation. He's listening from one end. So if you feel like he's not answering the question you want and you want to prompt him in a different direction, please just interrupt him and he'll continue. And so yeah, once you start using it, you'll get the picture. And I think Bernard, we have it on verbose mode or succinct mode. Because if he's talking too much, you can say, please, Isaac, get to the point. And he will be even more consistent and concise with his answers.
Yeah, like think about it like I mean, think about even if it's an AI system, it has human-like behaviors. So think about it as talking to a human being. Like, what would you tell a human being? Well, tell the system the same thing. Tell the AI the same thing, and it will more or less react the same way. It's interesting that all these AI systems have human-like characteristics. I mean, for instance, if you actually beat it down, and that's why we are going to ban people who use profanity, because it's proven that if you use profanity with it and you actually beat it down, the accuracy of its answers actually the accuracy goes down, and it's the same with every AI system. It's because they can't really they have this human-like behavior. You're beating them down. They don't really know how to respond.
Right, yeah. And there's an interesting question that's come in about the video input. It's very interesting. When we started this, we wanted this to be a dental co-pilot. But I'll give you an example. I had a patient that was very holistic that didn't want to take an amalgam out and was telling me that, you know, she really doesn't want the mercury vapor on her tongue and oral tissues. And I am dual qualified. I've been working for 15 years. I asked Isaac, what's the best way to take out this amalgam in front of the patient? So he understands when a patient's talking to him, and he'll dumb his language down. And what happened is that Isaac proceeded to say the best way to take the amalgam out today is under rubber dam using a high-speed vacuum, charcoal filtered mouthwash. And then the key to this was making sure you go around the periphery of the amalgam. This was an occlusal, by the way, and cut it in half. I have never been taught that. I'm from England. We did amalgams all the time. I think there's some other doctors from England. I've just never been taught that technique. That patient got up at the end of the appointment and said, I want to do the other 4 now. This is a patient that didn't want to remove 1, has now decided to remove 4. And I can go on with other examples. Shervin's not here today, but he has examples where in his perio office where he tells patients, hey, I think you should take the tooth out. He allows them to talk to Isaac. And Isaac then comes with a lot of back and forth as to the pros and cons, and then eventually talks about success rates of an implant versus, I don't know what he was talking about, periosurgery or even re-RCT in that situation. And patients are tending to listen to the AI. And it's not that it's wrong, it's just that it's a tiebreaker now in your office. And it leads me to the point that, you know, others are using it for post-op care, especially perio and surgical units. They've been very interested in how we can integrate that. Right now, what we want is this up and running with doctors, and all those features will come in at some point. Would you agree, Bernard?
Yeah, absolutely. I would agree. Yeah, and there's lots of things that you can talk about with Isaac. When it goes and take a look at treatment plans, actually it can actually go very deep. So you can talk about all the different phases of the treatment plan, alternative procedures, rationale for discarding them, pros, cons, risk-benefit analysis, risk selection criteria, progression criteria, clinical decision points, contraindications, lab tests required, clinical conditions, medical clearances, success probability, and anything that really your heart desires. I mean, it's really a thinking partner. It actually makes you think through cases.
Yeah, perio charting. Yeah, that's probably 1 hour work for Bernard. Can he speak in different languages? Yeah, he can speak in female, male. He can speak in your language. For the upcoming demos, we're going to have a deep fake where he'll probably be talking with a picture of a doctor there. So yeah, I mean, he could do anything. Like, let me tell you guys, right? The AI you see right now in your hands, it's the worst it's ever going to be. It is only going to get better from this front onwards, and we all have to make a decision. Do we want to embrace AI, or do we want to be on the other side of the battle? And what we're trying to do here is we're trying to create safeguards around what he's doing in terms of his co-diagnosis and co-piloting. And I think you'll find it very, very useful. You know, you'll find it extremely useful. Very nice job presenting. Can we use it to write surgical notes or referral letters? Yeah, probably an hour's work for Bernard. So what will happen is that I think someone mentioned about notes. Once the notes integrated onto the system, you'll have radiographs to pick from. He'll compile everything together. So he's no different in terms of ChatGPT in that respect, because that's a very fundamental thing to do. The key difference is you have a system here that's integrating your x-rays, or a CBCT in this situation, what you've done, because you've verbally told Isaac what you've done. He's created notes from that, and he'll easily be able to compile that together. So that's mostly just data entry. So that will not be a problem at all. So yeah, when you're writing to your doctors, Eric, it'll be very easy for you to tell your GPs what you've done in any situation, which implant you've used, etc. Not a problem.
All right, I think we're we're at time.
Oh, we got one last question.
Oh,
oh no, he said huge time save. Yeah, yeah, absolutely. Yeah, I mean that's what this is about, right? It's about efficiency. And I think Dr. Iyer was telling us, like, you know, it's time we're respected by the medical professionals. And this is probably going to help bridge the gap. We're going to have a lot more information at our fingertips. We're all going to elevate ourselves. And the way I look at this is, if you don't use something like this, you're either saying you know everything, and no one can know everything. So I really recommend everybody to try it out. There is a limited number because we have to pay on the LLM cloud aspect. There are some people already on it. There's still a bunch of other people that are still coming on to further demos. So please use it, because we have limited time on that. And I think you'll have a good time with it.